Hello and welcome to the Cancer Awareness Month. We are in week 2 of the Cancer Awareness Month now. My name is Kojo Akoto Boateng. Last week we got an introduction to cancers. We learned how cancers are treated. We learned how cancers are investigated. But this week we are getting into the cancers properly. And we are starting with one cancer, which is increasingly common in Ghana. Yet many people are unaware of warning signs or screening recommendations. Now, our guest this morning is a colorectal surgeon, and he'll be talking to us about colorectal cancer. That is cancer of the large intestine. Professor Jacob Dakubo, thank you so much for making time to be a part of the Cancer Awareness Month. Welcome to the Cancer Awareness Month, sir.
Thank you very much.
Now, Prof, before we get into the conversation properly, tell me a bit about yourself. You are Professor Jonathan Dakubo, a colorectal surgeon. When we say somebody is a colorectal surgeon, really, what do you do?
Thank you very much, and thank you to your listeners. A colorectal surgeon is somebody who specializes in the diagnosis, treatment of diseases of the large intestine and the anus. The large intestine is made up of two parts, the colon and the rectum. And the anus is the last part of the alimentary tract. So somebody who is specialized in making diagnosis and treatment of diseases affecting these three parts of the large intestine is referred to as a colorectal surgeon.
And on my readings before having this interview with you, I realized that colorectal surgeon is really increasing in the country. We've always known about the breast cancers, the prostate cancers, the liver cancers, the lung cancers, but I've not heard about colorectal surgeon, colorectal cancer a lot in our everyday discussions. Can you please tell us about colorectal surgery? I'm mixing the colorectal surgery and colorectal cancer. Can you please tell us about colorectal cancer and how it comes about?
Thank you very much. Yes, I mean, because we have not placed emphasis on this disease, it will appear that it is not common, but it is a common disease. Worldwide, colorectal cancers are the third leading cancers, and they also cause a lot of mortality. Every year, the whole world, we see about 1.8 million new cases, and about 900,000 people die from this cancer.
Wow. So about 50%.
In Ghana, we see about 400 cases every year. About half of them die every year. About half of that number die every year.
Wow.
And in Ghana here, we see about 400, and we are losing about 4,000, about 4,000 every year, and we're losing about 2,000 human beings because of this disease. So it is a common disease, even in our environment, which we have to do a lot of advocacy about, and then let people know that there are people who can treat it very well.
It's a cancer of the colorectal region, and as you explained earlier, the colorectal region is the rectum, the colons, and the passage that leads to the anus.
The anus.
Yes.
That's right.
How does it come about?
Yes. The word cancer by itself refers to a disease that we refer to as malignant. They are out of control. And these diseases come out of control because they have undergone a mutation in their genes. And cancers of the large bowel are one group of cancers that develop after at least 5 mutations have occurred. And these mutations don't occur at the same time. They occur in sequence, in which case a disease starts, which is not a cancer, but over a period of time, it develops into a cancer. So for colorectal cancers, they usually start as an adenoma or a polyp, and the polyp is not a cancer. Then if the polyp is not treated, it will accumulate a few more mutations and then become a cancer, and then that cancer can spread. So we say that colorectal cancer is one cancer we can catch at a stage where it is not dangerous and prevent it from developing into a cancer. So an adenoma or a polyp forms first, then that polyp develops into a cancer. So basically, this is the science behind colorectal cancers: multiple gene mutations, a polyp form which is not a cancer, more mutations occur, and that polyp now becomes a cancer. More mutations occur, then that cancer can now spread. So this is how it happens.
Now, Prof, to the layman, what's an adenoma? What's a polyp? What's a mutation?
Mutation just means that the normal arrangements in the gene has changed in whichever form. So a change in the gene from its normal structure into an abnormal structure is called a mutation, and that has become permanent. A polyp or an adenoma is a growth in the lining of the intestine. That is not cancer. So if the growth is cancer, we don't call it a polyp. But if the growth, we identify that it is not a cancer, we refer to it as a polyp or as an adenoma.
But how does something get to grow in the lining of the large intestines, for example? Because we know that a lot of things are moving through it every day. So it's being cleaned and washed every day. So how does something get to stay and grow?
No, it doesn't stay and grow. The growth is from the cells of the bowel itself. It is not something from external.
Okay.
It is the cells in the intestine that now start growing abnormally because of the mutation that has occurred. Because of the change in the genetic material, the cells are no more normal. They get out of control and they grow into a mass or a swelling in the intestine, and that is called a polyp.
Okay. Now, Prof, what are the warning signs of colorectal cancer that we should never ignore? What are the things we should look out for to let us know whether we are at risk or not?
Yes. There are risk factors that we know about, and we have the symptoms and signs of cancers of the large bowel. I'll take the risk factors first. The first risk factor is our diet. The first risk factor is our diet, what we eat. The incidence of cancers in the highly developed countries, Switzerland, Norway, Holland, United States, Britain, is more than 50 per 100,000 population. The incidence of colorectal cancers in Africa is still less than 4 per 100,000 population. And the difference is just because of the diet, the food that we eat. So when we eat food that has high fiber, food that we take from the farm and we don't process it and eat, then we are protected. But if we take refined foods that have less fiber in them, that are processed and they are preserved, the incidence goes up. The second factor is our colon health. How often do you move your bowel? People who don't move their bowels frequently are more at risk than those who move their bowels frequently. The next is exercise. Those who exercise or do vigorous activity are more protected than people who don't do physical activity. And that is linked up with weight. So obesity is a risk factor. The next is the intake of red meat. Red meat increases one's risk of developing colorectal cancer, especially when it is very cooked or very roasted, as opposed to taking white meat like fish or chicken. The other risk factor is alcohol abuse. If you abuse alcohol, then you have problem with vitamins in your body, and then that can predispose you to develop colorectal cancer. And then the last but not the least is smoking. Now, we have a genetic aspect of this problem that is hereditary. And about 5% of all the colorectal cancers we know about are because you have inherited a mutation from your parents or from your grandparents. So the genetic risk factor is there. Those who are genetically predisposed will always develop the cancer. But those who have the risk factors don't necessarily have to develop the cancer. So just to repeat the risk factors, our diet, we need high fiber diet. Our colon, we need to move our bowel frequently. We need to exercise to reduce our weight. We don't have to abuse alcohol. We should eat red meat, but we should intersperse the red meat with white meat. We should not abuse alcohol, and we should not smoke. These are the risk factors that predispose one to develop colorectal cancers. Now, these cancers, as I said, start as a polyp, which is not a cancer, but which over time, if not treated, will develop into the cancer. So these cancers will start without any symptoms at all. The polyp may be there without symptoms and may be diagnosed when we do a colonoscopy and we find it and remove it. That ends the story. But if it becomes symptomatic, the commonest and most frequent symptom is blood in the stool. We are not supposed to bleed from any of our linings, our skin, our mouth, anywhere. We are not supposed to bleed. The only place we are allowed to bleed from as human beings is the uterus, and the women bleed once every month. Otherwise, no surface is supposed to bleed. So once one notices blood from any of the orifices, be it the nose, the mouth, the urethra, the anus, it means something is going wrong. So bleeding is the commonest symptom of colorectal cancer. So when somebody finds blood in his stool or the occult blood test is positive, we have to investigate the cause and treat it. But when the cancer develops, some of the earlier symptoms include a change in bowel habits. Your normal bowel habit has changed. You used to go to the toilet once every day. Now you have seen that you are going to the toilet once every second or third day, and that's become permanent. Or you are moving your bowels more frequently than normal. The hearing of noise in your tummy after eating, a lot of large rumbling noise in your abdomen after eating. You feel very bloated after eating. You feel your tummy full. Sometimes you are belching a lot or you are having hiccups. That could be a sign of cancers of the large bowel. And then we have the vague symptom of dyspepsia. That is why many people with colorectal cancers are usually thought to have peptic ulcer disease. Abdominal discomfort that comes on after eating, or sometimes even when you are hungry, you feel uncomfortable in your abdomen, what we call dyspepsia, is the other symptom. And then we move forward to weight loss. In fact, colorectal cancers are some cancers that lead to a lot of weight loss, significant weight loss. If one is there and you realize that you are losing weight and you cannot explain, that could be a symptom of colorectal cancer. Then you are there, you suddenly realize that you easily get tired. You are feeling weak. You don't have energy. These are symptoms of anemia, that you have lost blood. And the cancer can be bleeding in small amounts for a very long period of time. And it is when you start feeling weak, you lack energy, you easily get tired, your heart is beating very fast, then the doctor examines and realizes that you are very pale. And the cause of that anemia will then be traced to a cancer in your colon that is bleeding microscopically. The other symptom of colorectal cancers is you can feel a mass in your abdomen. You lie down, you feel, oh, there's a mass or a swelling in some part of your abdomen. That is the cancer that is showing. But coming specifically to rectal cancers, the symptoms are very elaborate. The rectum stores feces and voids it. If you realize that after going to toilet, you still have a feeling that there is fecal matter in your rectum, you are going to empty your bile, you still have a feeling there is something in your rectum. That could be a cancer of the rectum that is doing that. Or you can have been repeated strong urge to go to toilet. The urge is so strong that you feel like if you don't hurry up, you swell yourself. We refer to that as tenesmus. That shows that there is something in the rectum that is giving that strong urge to go to toilet. And then we have what we call false diarrhea or fictitious diarrhea. You have a strong urge to go to toilet, you go and sit on a toilet bowl, nothing comes out. You will pass a little air, or you may pass a little phlegm. You get up, you go to wherever you are to sit down. In about an hour or two later, you have a strong urge to go to the toilet again. You move, you go, and nothing comes. When you start experiencing this symptom of spurious diarrhea or false diarrhea, it means there is something in your rectum that is doing that.
I see.
And then the size of your feces. Your feces is supposed to be bulky. But if you realize that your feces has become like pencil thin or comes out in pellet like that of a goat feces, that should be something you should worry about. So the symptoms of colorectal cancers are many, but the commonest I expect everybody to remember is bleeding. If we look for all patients who have blood in their stool and investigate them, we'll pick about 95% of all colorectal cancers.
Interesting. So, Prof, based on this, if I see any changes in my bowel habits, if there is blood in my stool, if there is persistent abdominal discomforts, false diarrhea, unexplained weight loss, if my stool is not the bulky stool, but this time is as pelletized as goats, as we see with goats and sheep, then there must be something wrong with me.
Definitely. You need to be investigated.
This is the Cancer Awareness Month on the Super Morning Show here on Joy 99.7 FM. My guest is Professor Jonathan Dakubo. He's a colorectal surgeon, and today we are talking about colorectal cancer. And so far, he's explained what it is, the warning signs, the symptoms, and all. But I want to know how to get screened. At least last week when we had a conversation about screening of cancers, we were told about different types of screenings. The ones the radiologists do, the one the anatomic surgeons do, and all those things. When it comes to screening for colorectal cancer, how is it done? And who should be screened for colorectal cancer? And when must one go and get screened for this?
Thank you very much. Yeah, of all the screening that we do, it is only in colorectal cancer that it has been shown clearly and definitely that screening actually reduces the incidence of the cancer and the mortality. And the reason is because when we screen and we see the polyp and we reduce them, then the cancer doesn't develop. So screening is very important in colorectal cancer diagnosis and treatment. The simplest screening we do is to try to find traces of blood in the stool. That's what occult blood test. So we have the guaiac and we have the hemocolt. And the second is the colonoscopy. So and the colonoscopy is far superior to the occult blood test. We have a flexosigmoidoscopy, which is done, but the main recommendation is that it should be a full colonoscopy if we are screening for colorectal cancers. Now, we say that anybody who is 45 years and above should do a colonoscopy once every 5 years.
Anyone who is 45 years and above should do a
5 years and
colonoscopy
above.
once every 5 years.
5 years, yes. And in between 2 to 3 years' time, such people can do the occult blood test. So 2 to 3 years' time, you can do an occult blood test after you have done the first colonoscopy. And in 5 years' time, you have to do a colonoscopy. That is the screening program we have. But we stratify people based on their risk profile, and that gives the definite or the appropriate screening schedule. But that is beyond this discussion. The basic thing we want our listeners to understand is that when you are 45 years and above, without any symptom, you have to do a colonoscopy. 2 to 3 years after the colonoscopy, you do a fecal occult blood test, and then the next 5 years, you do a colonoscopy. If we do these things, we'll pick the polyps early, and then we can remove them, and the cancers will not develop.
And how is the colonoscopy done? Is it painful? Is it invasive?
The colonoscopy, it's a bit invasive, so we will let you prepare your bowel. You are made to drink a liquid substance that will purge you. It will clear the large bowel of fecal matter. That is, you start that a day before the procedure. And when you come, you are sedated appropriately so that you don't feel discomfort, you don't feel any pain. And then the colonoscope, which is a tube of about 1.6 meters long, it is passed through your back passage. It has a camera, it has a light source, it has working elements. Will advance it slowly from the anus through the rectum, through the entire colon to the cecum, so that we'll look at the colon and see if there is anything there we can either remove or take biopsy. That is the standard colonoscopy. We also have the virtual colonoscopy, which is done like the bowel preparation is like the standard colonoscopy, But then this is a CT, so nothing is introduced into the person, but pictures are taken and can be reconstructed to show the bowel. The disadvantage of this one is that if the procedure finds a leaking or a disease in the colon, then the person has to go for a standard colonoscopy to either remove it or to take a biopsy. So those are the ones that we have. So in this country right now, we do the standard colonoscopy as opposed to the virtual colonoscopy. Because of the cost and the fact that frequently you have to go and do the standard colonoscopy at a second sitting.
Yeah. Now, Prof, you said that the tool you use for the colonoscopy is about 1.5, 1.6 meters long.
Yes.
That's about the height of one human being.
Yeah, that's the length of the colon. The human colon is about 100 to 1. About 1 meter to 1.5 meter long. Yes. So that's why the tube is designed that way. It can take the whole of the large intestine.
Okay. Interesting. This is still the Cancer Awareness Month. Prof. Jonathan Dakubo is talking to us about colonoscopy, but basically our conversation today is on colorectal cancers. And now we are talking about investigating the body to see whether someone is at risk of colorectal cancer. And so far, he says that there are 3 ways of checking. There's the stool examination, there's the colonoscopy, and with the colonoscopy, there's the virtual one, and then there's the full colonoscopy. And he would always recommend the full one because when you do the virtual one and something is found in your system, you'd have to do the full one again. So why not just do the full one and get to see how healthy or otherwise you are? Prof, have I summarized it right?
Excellent.
Now, let's get to treatment. How treatable is colorectal cancer? Earlier, you mentioned that it's easy to treat once we find a polyp. But in a country where people hardly go and check, sometimes you allow cancers to grow from one stage to the other. So generally, how treatable are these cancers? And what is the recovery process like?
Thank you very much. So for the polyps, it's very easy to treat. You see that endoscopy, we have a snare, either a cold snare or a hot snare. The hot snare ensures that bleeding is minimal or doesn't exist after you have removed the polyp at endoscopy. But the advantage is that sometimes it burns the polyp, and then the histology becomes difficult for the pathologists to interpret. The cold one, yes, you get tissue that has not been affected by heat. It's good for the pathologist, but then you say you have a problem of maybe having a bit of bleeding in your hands. So once a polyp has been excised completely, then you put a patient on colonoscopic surveillance. But once the cancer develops, the first thing we do in the investigation is to stage the cancer as stage 1, stage 2, stage 3, and stage 4. And stage 4 is the advanced stage. But whichever stage that we get, one treatment which is compulsory is surgery. Surgery is very important. The other modalities of treating this cancer has to do with chemotherapy, where the chemicals that we give target tumor cells that are spread in the blood or located somewhere else. And then we have radiotherapy, especially for rectal cancers, and we have molecular or targeted therapy. These are the treatment modalities that we have for these cancers. And the treatment of colorectal cancer or all cancers now is multidisciplinary. And we encourage all institutions that treat these cancers to have a multidisciplinary team. It helps to take a decision on how to manage a particular patient. So it's like precision treatment. You, the individual sitting in front of us, your type of cancer, your stage of cancer, your physical well-being, etc. All that is looked at, and the team takes the decision that this is the approach of treatment that we have for you. So the chemotherapy, the radiotherapy, and molecular therapy, these are in the domain of the oncologist, the medical oncologist or the radiation oncologist. The surgeon's role is to remove the part of the colon that is affected. And for today, we have 2 surgical approaches, either open or closed. In the developed world, when you are discussing colorectal cancer surgery with the surgeon, the default thinking is that it is laparoscopic. The uptake of laparoscopic surgery for colorectal cancer is 90% in the developed world. Unfortunately, in Ghana, ours is 0. And that is a lot of work in our hands to increase the laparoscopic colorectal surgical uptake in Ghana.
Is it that we don't have the human resources to do that, or we don't have the tools to do laparoscopic colorectal surgery in Ghana?
Okay, now I do all my colorectal surgeries at Mintuba Hospital laparoscopically. All colorectal cancer, colorectal disease are doing laparoscopically now. But the reasons why we are behind are about fourfold. The first is that as a country, we don't have a formal training program for laparoscopic surgeons. And that is a project that Mintuba Hospital is working on. The second problem was that we do not have the expertise. Surely, once you don't have the training, the expertise was not there. And then we did not also have the equipment for the training. The issue of the equipment is now largely being solved because in almost all the teaching hospitals in Ghana now, we have laparoscopic towers. And in some private hospitals, including my own, we have laparoscopic towers. I have 2 of them because of the training. The third reason was that the cost. Because the cost of laparoscopic surgery is not like the cost of the traditional surgery that we do. And last but not the least was because we were not offering it to patients. We did not have highly specialized, units in general surgery. You see, before now, general surgery was done by people who, colorectal surgery was done by general surgeons who operated on the neck, on the breast, in the abdomen, in the skin, everywhere. But since we started colorectal surgery as a subspecialty in Kolebu Teaching Hospital since 2014, we have developed very rapidly, and colorectal surgery is now, or can now be treated as it is done in the developed world. Like I said, at Mintuba Hospital, I have everything to make the diagnosis and to treat. And now we do all our colorectal cancer or colorectal diseases laparoscopically.
Great.
And the recovery is better because the patients go home in 3 days.
After the 3 days, how long does it take the patient to feel whole again?
In about 2 weeks.
About 2 weeks. And this is good. In 3 days,
yes, because
you get your surgery done. In 2 weeks, you feel whole again.
Yes. Yes.
Great.
Yes. Because, I mean, so far, all the patients who have operated, in 3 days, if I want to operate the following day, once you have reduced the amount of opioids going into you, your nausea has gone down, you do not vomit, we start sips. Then the second post-operative day, you start liquid diet. And then the third post-operative day, once you tolerate light diet, you are going home. Because you don't have any wound on your tummy. There are only small wounds in your tummy. And you realize that with that, in 2 weeks' time, the patient is eating normal diet, the patient is ambulating, the person can do office work, and that kind of thing. So laparoscopic surgery is for colorectal cancer or colorectal disease is far, far, far superior to the opening surgery. Where you have a very big cut in your tummy, recovery is slow, complications are high, and patients are not able to return to normal activity in a very long period of time. So one of the advocacies we are doing right now is to tell Ghanaians that yes, for colorectal diseases, we have minimal invasive surgery, that is laparoscopic surgery in Ghana, and Mintuba Hospital is doing it, and train the young guys so that it becomes the default surgical approach for colorectal diseases in Ghana.
Great. Now, in wrapping up, Doc, is colorectal cancer sex specific? Is it a male disease or a female disease, or is for both sexes?
Yeah, colorectal cancers is for both sexes. And even though the literature will tell you that the colon cancers affect more males than females, and then the rectal cancers affect more females than males, the difference is not that much. So the fine literature will tell you that the cancer of the colon affects males more than females, and that the cancer of the rectum affects more females than males. But in general practice, the difference is not that much. So it's not sex specific. It affects both sexes equally.
You've also mentioned that in your facility, which is Mintuba Hospital around Kaswa-Weja area, you are able to do everything related to colorectal cancer, from diagnosis to treatment and everything. But where else in Ghana can people get screened for colorectal cancer? And Is it expensive?
Yeah, colonoscopy is done in many centers now. Many centers, all the teaching hospitals have colonoscopes. Kolebu has, where my unit is. And Kolebu, we have a dedicated colorectal unit, which is on the surgical fourth floor. All the hospitals have them. University of Ghana Medical Center has. What do you call it? Bank Hospital has. Snit has. That's Trust Hospital has. And if you go to Confanachi has. Tamil Teaching Hospital has. Ho Teaching Hospital has. Cape Coast Teaching Hospital has. All the teaching hospitals have them. And there are a lot of private hospitals that also have them. But the problem we are encountering as colorectal surgeons in Ghana now is the diagnosis that are made. Because many people are scoping, and not everybody understands what he sees. So most of the time, when people come with their colonoscopy reports, when we look at the symptoms, sometimes we have to repeat them. And we see that what we have diagnosed is sometimes far from what others have done.
We need to.
So that is what also makes
the
the training of colorectal surgeons.
Mm-hmm.
Yeah, we have a lot of work to do there, because if you're a colorectal surgeon, your appreciation of disease of the large bowel is different from somebody who is a general surgeon or a generalist who is doing it. So most of the times, you see that we have to repeat the colonoscopy to be sure of what the person is talking about. Because bottom line, it is we, the colorectal surgeon, who is going to operate on the person. And we want to be very sure that what we are going to remove is what has been diagnosed. So we need to train more colorectal surgeons to understand colorectal pathologies. And when they do endoscopy and they give us a report, we don't have doubts about them.
Great. Professor Jonathan Dakubo is a colorectal surgeon, and today's conversation is on colorectal cancer, and we are wrapping up. Now, Prof, before we go, your final words, your take-home advice for all of us.
Yeah, my advice to all Ghanaians is that colorectal cancer is not a rare disease. And colorectal diseases are not also rare. Given that our population is now aging and our diet is also slowly changing, we are seeing diseases of the large intestine and anus now more frequently than they were being seen. These diseases are such that we should be able to cure people and people don't have to die out of them. The problem we have seen is that many people, out of fear, don't access appropriate quality health service. And we see them in an advanced stage. When we see colorectal cancer in an early stage, we can cure the patient at a lower cost. Colonoscopy is the gold standard diagnostic tool in disease of the large intestine. And today, all colorectal diseases are operated upon laparoscopically all over the world. Ghana should not be left behind. At Mintuba Hospital and Coloproctology Center, we do all our large bowel surgeries laparoscopically. And the recovery is fast, the cost is affordable, and patients are able to go back to their normal activities in a short period of time. Thank you.
Thank you so much, Professor Jonathan Dakubo, colorectal surgeon, talking to us about colorectal surgery here on the Super Morning Show, the Cancer Awareness Month.